Well, welcome. This is Texas State Senator Bob Hall, and we're going to be talking about the COVID and what our medical doctors are doing to address this issue and their successes. And many of you have seen our previous video that we put out that's been very popular, talking with 6 other doctors. And today I've got Dr. Amy Offutt from out in the Marble Falls area, who has also been treating patients in her practice and has found a lot of success. She sent me a diagram of her protocol, which is very similar to other doctors, with her own personal approach to it, of whether people are symptomatic or asymptomatic or high risk. And she has been using this and getting great results. And so I've asked her to join me here today and tell you about what she's doing and how she's going about it, and why she thinks this is the answer to moving from a defensive strategy of just mask and lockdowns and isolation to one of actually fighting the COVID in an offensive way. So Amy, welcome. Glad you were able to join us today.
Thank you, Senator Hall. It's an honor to get to talk to you. And I debated whether to actually participate in this or not, because there are some personal fears about putting myself out there. However, I have strong faith and I prayed about it, and the resounding answer I keep getting is that I need to share with other doctors, especially, that treatment is a good option. And there's really no reason beyond the usual reasons for treating patients to withhold treatment. And I think that's what is unfortunately happening right now.
And I want to thank you for that, Amy. I do know. And guys watching this, I hope you heard what Amy said, because it is a risk to her, because we have a very dysfunctional Texas Medical Board and Pharmacy Board here in Texas. And these doctors are putting themselves in jeopardy because of the politics, not because of the medicine, not because they're doing anything that harms a patient or is improper or not in line with general accepted medical practices, but simply because it's a political issue, that there are forces out there that don't want you to know that there are medical solutions to this. They want you to think that the only answer is going to come sometime in the far distant future with a vaccine that I don't think any of us want to wait for, or not wait for, or even to take. And so I have to thank you, Amy, for having the courage. And I know that you prayed about this. I pray about it every day, because I know I've put myself out there, but that's all been done now. I can't take that back. And so I'm in the fight to the end. And I appreciate you joining with us.
Well, I had some amazing mentors in my training who taught me that if I always focus on the patient, I'm doing the right thing. So that's my focus. And I think that's a common theme amongst a lot of Texas doctors. We focus on our patients. And, you know, for me, it isn't political. I know I have patients that have argued with me even on that. But when someone comes in and they're not feeling well, or calls and they're not feeling well, or has a medical problem, I don't ask them what politics they follow, or, I mean, it's not about that. It's about what tools do we have? What tools can we use? What can we do to be helpful, encouraging, supportive? And even with the things I'm doing right now, I still give the patients the same precautions. Like, I've treated 30 patients so far with COVID, and one went to the hospital, and it was because he didn't want to wear oxygen at home. He was in the hospital for 3 days on oxygen, and then he went home on oxygen and recovered fully. Other than him, who presented very late, none of the other patients have gone to the hospital. And you know, I don't have where I am a population of sick patients like, say, in Houston or the Dallas area, but I feel called to tend to the patients presented to me with the tools that I have in my toolbox to treat and take care of them. And I think other doctors could be doing the same without fearing negative consequences, as long as they're just focused on the patient and the patient's health. And I would encourage other doctors to use the tools they already know. Like, the things I'm using, I've used before. I know what they are. I know how they work. I know how they match with other medications. And I'm happy to share the protocols I've been using with anyone that wants them. Some of the things I do may be different. Some of the things will be the same. But if each doctor takes from the list of possibilities what they feel comfortable with, and then offers that to a patient who's sick with this virus, and still tells the patient, if you become short of breath or you become, incapacitated, obviously call 911 or go to the hospital. This is not to negate that option. It's to try to prevent that from happening. And if we focus on prevention, early treatment with the tools that we do have, every decision I've ever made as a doctor is a balance of risk and benefit, risk, benefit, risk, benefit. If I start someone on a blood pressure medicine, I ask myself, what are the potential side effects? What are the risks? What are the benefits? If it doesn't work, I try something else. It's honestly not different than what we already do as physicians. It's just new, and it's, the television has actually created so much angst and fear. And most of what the television presents or the internet is anecdotal. We talk about, double-blinded, placebo-controlled, randomized trials and not using anecdotal data to treat our patients. But what's on television is anecdotal. The story of someone who dies, it's dramatized, it's emphasized, it's made to create more fear. And I have been noticing in my patients, a lot of our phone calls are anxiety or sleeplessness or headaches or digestive problems because of all these fears. And I've sort of lined it out that one end of the population is fearful of dying. The other end of the population is fearful of losing liberty and freedom to go out and do. And so when we're all in a fear state, we're somewhat at our worst as far as being reactive or edgy toward each other. And somewhere in the middle of being realistic, reasonable, having common sense, using logic, is where I feel like the doctors could play a really important role in moving forward and getting past where we are right now. Because we can reassure our patients, we can educate our patients, we can take care of our patients, and then they have a less likelihood of having serious illness. And then once enough people know, half a dozen or 10 or 20 people who've had the virus and recovered, we can start to relax a little bit and understand more what it's really like to have the virus, as opposed to the television version of what most people have just been sitting in their homes and watching for months.
Yes, and the information, you're absolutely right. The disinformation out there is example, the study that was done in the VA hospital that was publicized so heavily that they said, oh, hydroxychloroquine doesn't work, it killed the patients. Well, it turns out that in the VA home, there was no real control of it. They gave them very high doses, right near, they were almost dying. They're close to dying when they gave it to them, very high doses. And hydroxychloroquine, like anything else, you give too much aspirin and you will die. And that's exactly what was happening. We went back, and as I was studying the literature, the stories about, the problems that people had with their heart and things like that, those were stories that were 50 years old when they were first started using it. We're upping the dose. This thing we have, if 1 pound works, we try 3 pounds. And obviously that's what they were doing. And they found that didn't work. That did not work, and it caused heart problems. And so they stopped doing it. But they stopped that 50 years ago. And they talked it in the doses of, I believe, 200 milligrams or 400 milligrams a day is as safe as taking a baby aspirin in there.
Well, even just today, we had a patient who does take some cardiac meds and has a pacemaker, has had some arrhythmias, and we selected something different for that patient. So it's the same thing we do. We look at each patient's, personal individual health, We make assessments. We choose interventions that are risk benefit based. And especially right now, when there's not anything being done for most who have this, except for go to the hospital, get tested. If you're not hypoxic, you go home and wait to either get well, suffer, or get more hypoxic and go back to the ER. Like if that's all we have, obviously the risk of that could be overshadowed by the potential benefit of some sort of early intervention. So selecting the right medicine is honestly a fairly simple, straightforward strategy for most physicians who treat patients day in and day out for whatever ails them. So, you know, I'm not sure why that simple logic has flown out the window right now, but I'm just taking care of each patient in front of me as they present and then watching the results. And that's what I've done for 20 years. I've been a doctor here for 20 years. And it's really no different than the normal doctoring. It's just done with maybe not as much peer support, but I don't know that we couldn't get there if we had a few more doctors start actually deciding to do some treatments.
Oh, I think we absolutely could. And what I was impressed with is when you first contacted us, you sent your protocols that you did, the way you approach it, which is very logical, the way you've just described it. And I know your treatments will vary somewhat from this, but in general, you divided it into symptomatic and asymptomatic and low risk and high risk. Would you like to walk us through your flow chart and your approach of a symptomatic patient?
Sure. So if someone's symptomatic, the first thing we would want to do is test. I have tested everyone that I could. I will say I have treated a few spouses who were symptomatic, whose husband or wife had a positive test as well. Like that's again, common logic. But as soon as I know someone is symptomatic and then positive, I will stratify that particular patient into low risk or high risk. The low risk patients obviously will need a little less supportive intervention, but based on their symptoms, I would place them on a few nutritional supportive supplements. I would consider putting them on a nebulizer protocol. I have one nebulizer protocol that's actually not prescription medication based. That's very inexpensive. There are other doctors in the United States who have used it extensively for years. And there was a published paper for 107 COVID cases using this actual recipe in a nebulizer formula that doesn't require any prescription. It's dirt cheap. Anyone could order it all on Amazon and have it at home. And I'm not touting it as the cure by itself, but certainly for someone who's low risk, who thinks they may have been exposed, to have that tool at home to administer to themselves or their family members could be helpful. So that's in my protocol as a low risk intervention that's possible. My protocol has shifted and changed as I follow certain other doctor experts out there who are looking at the studies from primarily European and Asian studies, because we're getting data from there that's very patient oriented, and they're a little further down the road than us, and adding and removing things from the protocol based on what seems best at that time. But the low risk patients do less, but are really prepared in case they become sicker to basically increase the level of intervention for those patients. And what I'd like to do is, if there are any doctors out there who want that protocol, they can just go to my website and put an inquiry there. I will be glad to send them my typed out protocol. I'm happy to share it. I mean, obviously it's not to replace their own medical knowledge or medical expertise, but it's a starting place. So anything any doctor felt comfortable using from the protocols I've been using, I would encourage them to do so with the same precautions. If the patient gets sicker, they go to the emergency room or call 911. So in the high risk group, a lot of patients don't know that they're high risk, which is a confusing part of kind of the lack of education, I think, from coming from the sources where we're getting information right now. The patients that are high risk, of course, everyone knows that if someone's older, they're at more risk. But I've noticed in my patient population, it's not really age. It's really that people who are older have more underlying disease, statistically speaking. I have some very healthy older patients who've done great, who really don't have any medical problems. And my sickest patient was under 50 with undiagnosed, basically metabolic syndrome. And so the patients who have high blood pressure, the patients taking a lot of medications for cardiac issues or blood pressure issues, patients that are more than 30 on the BMI, which is a huge percentage of our population, they fall into that higher risk category. It doesn't mean that they're going to have to go to the hospital. It means that we might want to be a little more aggressive with our interventions to prevent progressing disease. So that's how I'm stratifying it. I'm looking first at, if someone calls and they're asymptomatic but exposed, I have a protocol for them to follow. If someone calls and they feel ill, we're encouraging testing, and then we're treating them based on their risk. And so far, so good. For the first 30 patients I've treated, I have felt that worked very well. I'm not trying to spend a fortune for the care of people. I'm trying to honestly find an inexpensive, practical, logical approach that people can do at home and help each other to do, even in their family members. I'd rather treat early and watch and follow than to not treat and wait and be afraid. I mean, that even provokes fear in me, to wait and be afraid that my patient might get so sick. These patients I've known for 20 years, some of them, like the last thing I would want is to wake up and find out that they were on a ventilator in the hospital. And I don't think I have to do that. I think I have tools to use to prevent that, at least good odds of preventing it based on what I've done so far. And I would just love it if other doctors would start doing the same thing. I think it would be a wonderful thing for the Texas population.
Yeah, particularly that time frame between first feeling a little bad and being very sick can vary. At least that's been my observation with folks I know about that have ended up, unfortunately, in the hospital. It may have been, a week to 10 days between the time of first feeling bad and getting that sick that they headed off, and others just 2 or 3 days, almost seeming like almost overnight, going from just a little heavy breathing to really serious heavy breathing. So it's clearly a virus that affects people differently, and you do have to treat the individual patient with what you're observing when you see them in there. And so, but I think, and what we can do is we will put up your protocols when we put this together, so people have been able to watch them there. But I want to thank you so very much once again. Very glad that you could join us. Is there anything else that you would like to say to the folks before we work this thing towards a close?
I'm prayerful and hopeful that the word gets out that there's early intervention options for more people, so that we can start to get back to living. A lot of my patients are suffering right now with anxiety, depression, sleeplessness, stomach aches, and it's because they haven't really received that message that there are things that we can do that will help. And so if that, that would be the main message I would want to get out. And I'm praying every day that more people will resolve and heal after this virus, so that we can actually move forward and get back to more of our normal interactions with each other, more hugs, more handshakes, more. And I hear people say that's never going to happen, but I feel like as resilient people and loving, caring people, we can get back to that. We just have to take care of each other.
You're absolutely right. And it just really bothered me when I hear that, of people talking about, no more hugs, no more handshakes. And living, social distancing. That is absolutely absurd to talk about that. But I feel that the only reason we're doing that is people still have in their mindset that there is no cure for this. There is no medical treatment. And if you get the COVID, you're going to die. And that's just what people have in mind with this. And as a result of it, though, what I am hearing in other places, or I'm seeing, is that the corollary collateral damage that we're doing to not just the economy, but to the health of people, to their mental state, their physical state, is deteriorating very rapidly. I know the incidence of suicides are up. The incidence of highway accidents are up, and highway deaths are up. We have a number of industries that people have, this reported, well, it was over 6 weeks ago that we already have one airline that had 6 of their pilots committed suicide over the mental stress of the financial issue. And we've had others that with the hospital shutdown. Are you seeing patients that are coming in not for the COVID, but for stress-induced ailments that they feel a need to see you?
Well, last time I checked, which was a little over a week ago, we actually had more suicides here than we had deaths from COVID. And we don't normally have those kinds of numbers. So, you know, I wouldn't want to erase the precautions that people take, especially if they're high risk. And I don't want to imply by saying the things I've said that certain people shouldn't be careful. But I think we've taken that, you know, we probably needed to quarantine for a couple of weeks at the very front end to kind of get our bearings and get a plan and get together. And then it, to me, would be appropriate to let the healthy people start to intermingle more. And I mean, actually, my kids went to summer camp this summer. There were 200 kids at camp. Camp did everything they could to be precautionary, but the kids had so much fun. 2 of my kids went. We've had, you know, more campers come out to the same camp. And, you know, I don't want to jinx myself, but they've had a really great summer. I'm one of the camp doctors there. And, you know, we've been careful, but we also see the benefit, like the long-term benefit of being outside, being with other people, learning new things, reaching new goals, spending time, you know, becoming more independent. And to lose that, you know, I think we just have to get practical, and we have to get some common sense logic and use it to make forward progress. And I feel right now we're kind of stuck. And so my hope from doing this today is to make some forward progress and become problem solvers instead of complainers. Like you know, I teach my kids and I tell my staff in my practice, whiner complainers is, being around a whiner complainer is like one of the worst feelings. But if you attach a solution to the complaint, now you've got a problem solver. Problem solvers are inspiring. They're put out good energy, like people look up to them. That's leadership. That's what I think you're trying to do, is find a solution to this problem. And we can do it one patient at a time. And as other doctors maybe get a little more confident, a little bit more independent thinking, and start to intervene on behalf of their patients more frequently, I think it will just grow from there. If we could just start with that, I think that would be a great starting solution to this problem. And then what comes of that would hopefully be some transition back to more normal interactions with each other, which we really need right now.
Absolutely. And I agree with your description there. One thing I would say that our problem is not having a medical solution. That is not our problem. Our problem is getting our government leaders to accept the fact that we have a medical solution and that we need to shift our strategy from just being on defense. We don't get rid of defense. We'll always need to have defense. But like any team, you got an offense and you got a defense, and both have a role. the defense keeps the other side from winning, your offense is what wins for you. And so while we use our defense of our mask, our isolation, and where it's appropriate to be used, particularly among the most vulnerable, we put into play our strong offense to defeat the COVID with the medical professionals that are out there that know what they're doing, that we need to solve the problem of our government standing in the way of them doing what they do best, that is heal people. And I want to thank you so much for coming on and being here with us. God bless you in your practice. And I know we'll be staying in touch, and you'll be back to give us an update on what you find as you learn things that are new. We'll relay those to the people and to the other doctors out there, and look forward to seeing and talking with you at another time. So okay. God bless you, and God bless Texas.
Thank you. Thanks for what you're doing. I appreciate you very much.